Hello, hello. Happy Friday, everybody. Welcome to another version of Virtual Morning Report. It is still RLR, but with a twist. I would call it an upgrade because we have our dear friend and VMR guru, Ravi, who is stepping in for Prof. Rez, who is actually rounding with his team as we speak right now. So super thrilled to be able to co-facilitate with the beloved Ravi. And as always, before I pass the mic to him for him to say hello, would love for anyone to see if you all have a case to present to Ravi and I. All right, Ravi, say hello, please.
Hello, everybody. It's just great to see everybody here today, and it's an absolute pleasure and blast to be able to help out today and co-facilitate with Ravi. And hopefully we have a case which will be challenging, but not too over the top. Like last time I was here with Reza and we had HLH, and I was like, it can't be HLH, come on. It's VMR, come on. But it was HLH, and Franco presented that case, I remember. So we'll see if somebody has a case.
Ravi, there's a treat for you, my friend. There's a treat for you because my dear friend Ariel has as a case. I know a little bit of background. I don't know the case at all, but I know a little bit of background. And before I pass the mic to her, I just wanted to thank everybody who has the ability to turn their video on. Jad, Nalayan, Haley, Nadia, Yasmin, Hans, and Lee. Thank you all so much. Oh, and there's more. Diana and Jayan, first time meeting you all. Pleasure. Thank you for showing us your faces. It makes it that much more fun to be here. Of course, I've been in many a time where I couldn't turn my video on, so appreciate you all who can't and still are joining us today. Ariel, tell us about yourself, please.
Hello. Can you hear me?
Yes.
Great. So hi, everybody. I've been hanging out here for a little bit. I am a rising second-year vet student. And every time I join the virtual morning report, I'm just so impressed at how good and systematic and logical and knowledgeable everyone is. And that's what I hope where I would be in, I don't know, 4 or 5 years. So today I'm very, very excited to share a veterinary case with you. It's pre-approved by Curtin. Thank you. Thank him for that. I don't know whether he's here. I hope it's relevant. It's a very interesting case.
Amazing. You know, I would always share to folks that I would be terrified when they present a pediatric case. I don't know how much more terrified to learn of a veterinary case, but you promised me that there's a lot of overlap, so we'll give it our best shot. Ravi, how do you feel about illegally discussing a non-human case?
I think it's great. I was actually looking up for some coagulopathies, and I found a vet case, so maybe something interesting to look at. And plus, we both have dogs, so maybe it's a dog case. I've had cats, maybe a cat case, so it'll be very intriguing.
Cool. Shall I start?
Yeah, go for it.
All right. So, where's my screen? The chief complaint is a young cat, with severe anemia. So a little bit intro. Boo is a 3-year-old male castrated domestic short hair cat, just a common breed. Very young age. He was referred to the veterinary teaching hospital by his primary care veterinarian for severe anemia. So the owner brought him to the primary care vet a day before after noticing him losing weight for about 2 weeks. He may have been eating a little bit less, but still eating. His energy level, daily routines, drinking, urination, defecation all seemed unchanged. Upon his vet visit yesterday, he was found to have lost about a quarter of his weight. So he weighed 5.5 kg 2 months ago, and he weighed 4 kg on the last visit yesterday, and he had a hematocrit of 10%. And the normal hematocrit for a cat is we expect to be somewhere between 35 to 45%. That's all.
Oh my gosh, Ravi, please take it away.
Incredible. Just before we start, Ariel, the 3 years old, how does that translate to human years? I forgot the
very young, like a 20-year-old.
So 20-year-old. Okay,
Yeah,
so
fully grown, but yeah, adult.
okay, so a mature 3-year-old cat, about 20 human years, coming in with weight loss and also a very low hemoglobin. So what I'm trying to consider here is the weight loss maybe a harbinger of an ominous disease. Maybe something comes in. First, is the cat getting nutrition or having access to nutrition? Or is the cat having some digestive issues? Or is the cat having something like a malignancy, so like a hypermetabolic condition where something maybe just tapping in like a parasite, or malignancy can act like a parasite, but the cat can also have parasitic disease, which could also tap into the digestive system and decrease the caloric availability to the cat's system. The anemia, the landscape, I know Ravi mentioned this was very powerful. I love anemias, but the landscape of anemias is just so vast. So I don't know where to start. Is this anemias because of a bone marrow issue? Is this anemias because of peripheral issue? But I think we'll narrow down that focus as we get more data. Ravi, anything to add?
Yeah, no, I'm just so intrigued by this. I'm having a blast writing the teaching points, with the first being the human years equals cat years times 7. I don't know, is that fair, Ariel? Like, I just basically guessed what you did from this instance. Is that a rough estimate?
Yeah, it's very rough. It's not scientific at all.
Okay, all right, cool. We'll I'll put a caveat on it in a second, but I think the key dimension in this case is, as Ravi outlined, both a 10,000-foot view of each schema, weight loss and anemia. I think you have to ask yourself, how often is the workup of anemia going to be a diagnostically fruitful exercise in a patient with weight loss? And the truth is, the vast majority of anemia in the context of weight loss is not going to lead you directly to the answer, because the most common reason is you have anemia of chronic inflammation, which bears no specific signature of the underlying cause of inflammation. And here, I think that is probably not true because of one key variable. The vast majority of anemia of chronic disease is moderate to mild anemia, rarely below a hemoglobin of 8 or 9. So that would translate to a hematocrit of 24, multiplying by 3. Again, a very crude estimate, just like the cat to human year exchange. So here, why is the anemia worth significantly investing in? It's because the depth of the anemia cannot be accounted to just anemia of chronic inflammation alone. So I completely agree with Ravi, is we have to pursue both pathways. But that is probably in stark contrast to most cases of anemia in the context of weight loss, where unless you have iron deficiency, you're probably not going to go to somewhere specific. And the final thing I'll add is, I'm most curious now about the company that the anemia is keeping on the CDC. Is this an isolated anemia, or is this a bi or pancytopenia? That'll also change the landscape significantly. All right, Ariel, Mike, to you for more data.
Absolutely love it, and love everyone's been texting in the chat box. I'm going to offer more information. So Boo has previously been completely healthy. He is an indoor only cat, lived with 3 of his litter mates. All of the other cats appear healthy. All cats are up to date on their vaccinations, and they receive flea and tick prevention, which also helps intestinal parasites. His annual exam was 2 months ago. He appeared completely healthy, so no blood work was performed due to his young age and his normal physical examination. So on physical examination today in the referring hospital, his temperature, heart rate, respiration is within normal range. His mucous membrane was pale with normal capillary refill time. He has a grade 4 out of 6 left-sided systolic heart murmur with regular rhythm. Femoral pulses were strong, synchronous, and symmetrical. There were 2 linear regions of retinal hemorrhage in both eyes in the fundus exam. Boo appeared to be visual. His pupillary light reflex and menace responses were intact. All other systems were normal. There was no organomegaly or lymphadenopathy appreciated. His blood pressure was normal. And I have some basic lab work. His CBC shows a severe macrocytic, normochromic, non-regenerative anemia with hematocrit of 8%. He had a normal white blood cell count with a mild neutropenia, with normal platelet count, but with many macroplatelets. There was mild agglutination noted on the blood smear. Chemistry panel had an elevated globulin, which was 7.2 gram per deciliter. The reference range is 2.8 to 5.4 gram per deciliter. He had a low cholesterol, and everything else within normal range, including BUN, creatinine, liver enzymes, bilirubin, glucose, albumin. Albumin was on a lower normal, and electrolytes were all normal too. qPCR on like a panel of feline hematogenous pathogens were all negative. FIP, which is a cat disease that could cause hyperglobulinemia, was also negative. His ANA came back positive at 1 to 1,280. His vitamin B12 was within normal range. Abdominal ultrasound showed diffusely thickened intestinal muscularis and submucosa, which is non-specific finding, usually with like mild IBD or intestinal lymphoma. There was a slightly enlarged left medial iliac lymph node noted. All other abdominal organs and lymph nodes were within normal limits. And that concludes this outcome.
My gosh, Ariel, this is very, very juicy. Ravi, maybe I can tackle the background information and the exam and leave the labs and the rest of the data for you to analyze. You know, I think that like the purpose of the background information is to give you a sense of the tempo of this disease, and somebody having a thorough annual exam 2 months prior confidently lands you in a time course within that period. But the truth is that a disease may be smoldering under the detection of the providers before it emerges. But it's a fair operating assumption until you get more data to suggest otherwise. And what does the exam do? I think the exam is pretty concerning. Whenever you hear a systolic murmur this loud, you have to worry about a cardiac issue. But there are exceptions to when a systolic murmur may have nothing to do with the heart itself. And a common example are flow murmurs related to fever and anemia and hyperthyroidism and pregnancy. So a flow murmur from those 4 things could be at play. And then less commonly, but important in young humans at least, is to entertain the possibility that the murmur represents an aortic problem, specifically a coarctation of the aorta, which is not at play here, but something to recognize that a murmur doesn't always mean a heart issue. But I think the most concerning thing on exam, which is then corroborated by the labs, is the fact that the mucosa are so pale and that there is bleeding with the retinal hemorrhages. And so I think that sets you up well to expect the labs that you have. In fact, it might be an argument to have gotten them, because that's what the role of the exam is to tell you what you should do next. And this exam tells you, I'm really worried about this patient's exam and I should get some basic labs. And boy, how helpful are they? Back to you, Ravi.
Yeah, it's a abundance of data here to sort of sort through. So we'll start with this CBC. Definitely that hemoglobin is seriously low. Macroplatelets, I guess that would signal something happening within the bone marrow. And then MCV high tends to make me think with macrocytic anemia, of course, folic acid, B12 deficiency, maybe something to include, but with macrocytic anemias and having bone marrow issues, you think about a myelodysplastic disorder. Sorting through the chemistry, not a lot here. The albumin is low, and again, it could be a negative acute phase reactant, but then what really stands out is the total protein of 7.8. So then you wonder what is indeed going on here. And once you deduct the albumin for the total protein, you have about 4.8. I don't know in cat chemistry if this is significant or not. So the abundance of the extra protein may be secondary to this possibly a hypergammaglobulinemia. ANA of 1 to 1280, that is high. I know in humans, 1 to 80 and above is significant. So we don't know if this is signaling connective tissue disease. And again, I don't know the manifestations of connective tissue disease within cats. Some of it may overlap and cross over. And going back to what's interesting, when Ravi mentioned iron deficiency anemia, I was just wondering, do cats' claws have sort of like a koilonychia as well? The mucosa, pale mucosa, I guess, is due to the anemia as well. Maybe conjunctiva. Do the conjunctiva also exhibit paleness in anemia, Ariel?
Yes, we do.
Okay.
But it's usually pretty pale to start with.
Okay. And yeah, at this point, I'm not sure which direction it goes to. Any ideas, Robbie? I'll let you jump on them and crunch the data.
Totally. No, I think this is very tricky, and I think it goes to show you when you're asked as a learner or as an educator on the wards, what's your approach to anemia? It's hard not to be like, I don't know. And the reason is, I think you shouldn't have an approach to anemia. I think you should first localize the lesion into 2 categories and then have an approach. And I think the first category is, what's the time course? Because acute anemia is only one of 2 things. It's blood loss or hemolysis. And then you should also be aware of what is happening around the CBC. Is there anemia, bicytopenia, or pancytopenia? So if we try that exercise here, by the fact that we still, Ariel, I should also ask you, what do you refer to the pets as when you're talking about them? Do you use the word patient, or what word do you use?
Patient.
Oh, amazing. That's so cool. All right. So the patient here, the patient was well 2 months ago, well enough to have to not just well by report, well by direct examination. So I think you can confidently say this anemia is on the time course of acute, and then it's an fairly isolated anemia. The mild neutropenia is noteworthy, but the reason I wouldn't call it a bicytopenia is the hemoglobin is way out of proportion in terms of the degree of leukopenia. So there's a little bit of an error in being confident that it's just an isolated anemia, but you have to do something to be able to move forward, right? So what is acute isolated anemia? Oh, geez, it's the simplest problem in the world. It's either blood loss or hemolysis. But again, you could have a hyperacute bone marrow disease, as Ravi mentioned, that would cause concern, like AML. But I think you have even more compelling case that it's a hemolysis by virtue of the fact that the platelets are big, meaning the bone marrow is trying to churn out early platelets. The macroplatelets here are basically the equivalent of reticulocytes for the hemoglobin. And the fact that you see agglutination on the blood smear is another sign that you might have hemolysis. And when you look at what causes of hemolysis might be at play, one of the biggest ones is lupus. And so here you are with a positive ANA, agglutination, a high protein gap. And the key question is, do cats get lupus? So I would be Googling that. But, in humans, a young person, albeit as a male, would be a little bit less likely. I think this case is pretty concerning for that possibility. So I think I would chase down that hypothesis with getting a reticulocyte count and LDH. I would pay very close attention to the urinalysis because the creatinine may be normal in lupus, but the UA may be abnormal. But where are we, Ravi? I think we're in the but open to the fact that it might be actually more subacute anemia, and it actually might be leukopenia and anemia with this operating framework being incorrect. All right, Elia, please educate us.
I love it. I love it. So one thing I want to note is the cat appears clinically well. Like, he's pale and everything, but he has like a normal mentation, and he's playing and he's eating, might be with like low appetite. But if this is like a really acute process, we usually see a very, very sick animal. And for Deborah, the albumin is 2.8 and the globulin is 7.8. 7.2, and the total protein is 10%. So it's like a huge protein gap. Okay. That's all. And the next aliquot, serum protein electrophoresis shows a polyclonal gammopathy. If you need more detail, I can go with that, but yeah, polyclonal. And we did a bone marrow aspirate, which shows a very high cellularity, a large monomorphic population of small lymphocyte, estimated to be over 30%. And in normal cat bone marrow, we usually see lymphocytes of like around 20% or less. These lymphocytes are small in size and have a very high nucleus to cytoplasm ratio. They're round to slightly indented nucleus and smooth chromatin pattern with occasional prominent nucleolus. Plasma cells appeared increased in number and flame cells are observed. Granulocytes to erythrocytes lineage ratio is markedly decreased. Erythroid precursors in all stages are seen in increasing numbers. Occasional macrophages are observed that have phagocytosed metarubicytes, polychromatophilic erythrocytes, and mature erythrocytes. Immunophenotyping was performed on bone marrow aspirate. Small lymphocytes are approximately 90% CD3 positive, so T cell marker, and approximately 10% CD21, which is a B cell marker. Clonality tests, the cells were reproducibly polyclonal for 2 T cell primer sets and 3 B cell primer sets. Flow cytometry of peripheral blood reveals a homogeneous expansion of B cells. PARR assay showed no evidence of clonally rearranged immunoglobulin or T cell receptor genes. That's all.
Oh my gosh, Robbie, I'm going to pass the mic to you since I blabbered so much at the end.
Yeah, what really catches my eye is polyclonal SPEP, this could be due to, we're not in the domain of monoclonal issues, so polyclonal could be due to the massive amount of inflammation, but with this bone marrow, small lymphocytes greater than 30%, you have a high predominance of this cell type, and plasma cells increase in number. So plasma cells, especially with this polyclonal manifestation, you're thinking about conditions where possibly this could signal leukemias, but occasional macrophages with phagocytosis, that I'm not sure what to make of that. What kind of conditions where the macrophages may go overboard and start phagocytosing cells. The lymphocytes, I have to look up these CD3, CD21 markers to determine where does the answer really lie. But maybe I'll pass the mic to Robbie to see if he remembers any of these markers.
No chance. Absolutely no chance, my friend. It's amazing how much clarity that we have, though. Like you said, you know that the answer lies in analyzing these cells, and that will take you to the conclusion. And I have no idea what these cells are. I just remember a very basic concept, which is that the lymphocytes differentiate into plasma cells, but there is a cell in between called the lymphoplasmacytic cell. And in a human patient, this patient has features of that cell being the problem, because that cell causes the clinical syndrome we know as Waldenstrom's macroglobulinemia. And it is a disease, Waldenstrom's, a disease of that cell because it does secrete a paraprotein, usually a monoclonal IgM, that causes red blood cell agglutination and a hemolytic anemia that Ariel told us on the peripheral smear. And it has features of both lymphocytes, which are increased as we see, and plasma cells. And it is called the lymphoplasmacytic lymphoma. So I'd be curious about that possibility, because it is one of those diseases that is a bone marrow syndrome that causes a high protein gap that can cause a cold hemolytic anemia and causes both plasma cell issues and lymphocyte issues. So I would look into that possibility, but I think you now know that this patient likely has a liquid malignancy of some kind. definitely involving the bone marrow, and likely, as Ariel told us earlier, involving the intestine with the ultrasound findings. And I'm not sure what that means in cats. In humans, it means that this is an extranodal lymphoma, meaning a lymphoma not centered around lymph nodes. So I don't know what the base rate of extranodal lymphomas are in people, let alone in non-human patients. But I think that this is a great exercise in showing how valuable bone marrow can be and how expertise is needed in really understanding all these findings, which I completely lack. Ravi, I know, have you had any other thoughts since I've been babbling away, or should we pass the mic to Ariel?
Yeah, that was, it was interesting looking at the physical exam, retinal hemorrhages. It did pop out to me. It's interesting you mentioned Waldenstrom's macroglobulinemia, but what do you say about this SPEP being polyclonal? Wouldn't we have a monoclonal gammopathy in this case? And you know, in a human patient, you'd have the constellation of signs and symptoms you have with the dilated retinal veins, papilledema, these flame hemorrhages, and then the lymphadenopathy, hepatosplenomegaly, all this you put together. And I know there was a nice RLR of this where Reza nailed it. And that was if anybody wants to listen to Waldenstrom's macroglobulinemia case, that's the case to listen to, because it really clearly outlines how somebody presents. But in this case, it's very fuzzy right now, the picture. But what made you thought about that, especially with this aspect?
I completely agree with you. I think that there are probably a few holes in Waldenstrom's, applying this to humans, which is the age of the patient. Most Waldenstrom's is in older adults. The lack of finding of a IgM paraprotein is a significant ding against Waldenstrom's, and you might say that is a true SPEP that is negative, or you might wonder if the SPEP is false negative and you need immunofixation or serum-free light chains to guide you there. Yeah, I think there are a lot of holes in the hypothesis of Waldenstrom's, and that's why we often lean on analogic reasoning, because as you point out, this patient has signs of hyperviscosity with the retinal hemorrhages, has a big total protein, has lymphocytes and plasma cells in their bone marrow. So analogically, that maps onto the human disease of Waldenstrom's. And so, I'd be like ferociously Googling Waldenstrom-like diseases in cats or something like that to get to the answer. But there are many holes. And to add another one, the ANA is also, an ANA of 1 to 1280, that's a big, big ANA. I don't know how well that lines up with Waldenstrom's as well. So there's definitely a big protein gap, but an even bigger gap in my knowledge here.
Right. You mentioned that Waldenstrom's has a cold autoimmune hemolytic anemia, but I remember lupus has a warm component, hemolytic anemia. So it would be IgM in this case. So definitely immunofixation, like just stepping back and going through the exam, and then just what really stood out. If we map it out, it does lead to what you've mentioned with the bone marrow being an issue. Then you're having this protein gap for learners early in this process. That protein gap, definitely calculate it when you see it, because it might signal a plasma cell dyscrasias. Then what kind of plasma cells dyscrasias? There's a vast number. We had a solitary plasmacytoma case a little while back. Remember, Ravi? That was I've never had a case of that before, but that was very educational. And then going through the bone marrow, and you see that signaling that there's something in the bone marrow, and there's an abundance of cells, especially these small lymphocytes. But we'll get more detail from Ariel regarding that.
That is absolutely brilliant. So before the clonality test and the immunofixation came back, we were operating under the hypothesis that this is a chronic lymphoplasmacytic leukemia, which I do believe it's like very similar to the Waldenstrom you guys have been talking about. But we were taken aback by that, polygamopathy and the polyclonal clonality test. So at that point, we were quite lost, but we were hypothesizing that this is probably an immune-mediated disorder causing a polyclonal T cell expansion in the bone marrow, leading to multiple lineages of cytopenia. So he was put on low end of immunosuppressant dose of prednisolone and chlorambucil. I don't know whether you use that drug, but it's like either for chemotherapy or in low frequency pulse dose to treat some immune-mediated diseases. So he responded really fast to that and very well throughout like 2 years and a half to this combination of medication. So for those 2 years and a half, he came back for recheck blood work every month or so, and he consistently has a slightly low to a lower normal hematocrit, like 28% to 38%. Clinically doing well at home, and his globulin remained to be high throughout that period. So around 2 and 5 years into the treatment, due to the continued remission of whatever caused his symptoms, his clinicians tried to taper down his immunosuppressant. On the next recheck 1 month later, his hematocrit dropped to a 25% with no regeneration. He had a mild neutropenia again and a very mild thrombocytopenia with many macroplatelets. So we upped his dose and frequency of the same drugs, but there was no improvement of the blood work on the next recheck. He was still clinically doing well at that time point, normal energy, normal appetite, everything was good, just bad blood work. So he was scheduled for another thorough workup with possible bone marrow biopsy. And this is the second to last aliquot. The diagnosis will be reviewed on the next.
Oh my gosh, I forgot that I was supposed to be scribing because I was so engaged in this reflection. I'll catch up in a minute after I pass the mic to Ravi. And I think maybe Ravi, what I can do is just sort of summarize what I think the data that we got, and maybe pass to you to analyze while I catch up with the scribing. So we started this patient on immunosuppressive medication, targeting the hypothesis that there is a combination of a malignant process being driven by some kind of autoimmunity, which is a very common feature of many human diseases like CLL with autoimmune cytopenia. And the patient was doing well for 2 years, 2.5 years. And upon cessation of that immunosuppression, it appears the disease got out of control with worsening cytopenias and worsening hematocrit, and now no longer controlled by immunosuppressive therapy. Is that a fair summary, Maria? Okay, perfect. Ravi, what do you think?
You know, what Ariel mentioned, first of all, this is amazing that you really go deep into this with cats, especially because a lot of times we don't know what, we take our pets to the vet and what goes on behind the scenes. But isn't it remarkable, Ravi, that a lot of what they do is parallels exactly what we do? So that's my mind is blown with this case, especially. And definitely a lot of teaching and learning from this case that overlaps into internal medicine. But you mentioned CLL, which usually when we think about is one of the leukemias when you relate it to the epidemiologically to the age. Usually we see it in older adults, maybe 60 to 80 range. And if we go down the list of CLL, what can happen where the patient is treated and then something worse happens, they start deteriorating? So maybe there could be an infection that could be brewing due to the immunocompromised status. But what is more of an ominous, progression is something called Richter's transformation that you can have. So I'm kind of wondering if something like this is happening in this patient that you're presenting. So, and also you mentioned with these small lymphocytes, could this be small lymphocytic leukemia because there is a medial iliac node? But then again, I would want to see a preponderance of lymph nodes in this patient. So I'm wondering if something has changed and now we have to switch our thinking from CLL to something like a Richter's transformation where you get the change of this CLL into a more aggressive form like a large cell lymphoma. What do you think, Rob?
I think that there's sort of two dimensions to this case. One is, what was this lesion all along? That I don't feel much confidence about. What I do feel more confident about is exactly what you said. Whenever something that is in the liquid tumor space takes off, it's either disease progression or Richter's transformation. So I think you have to worry about that here. What I was doing in parallel was trying to see with more clarity, what is the underlying lesion here? And for that, let me just share a quick schema with you all. 1 second. Okay. It's going to take me about a minute to pull it up, but it might be worth it. We'll see. And the real question that I was trying to answer was, are there any malignancies that have that present with autoimmune disease more frequently than others? And I think the answer is yes, possibly. And here's the list. Ravi mentioned CLL. There's also this entity called large granular leukemia, which actually presents, ultimately results in Felty syndrome and RA and neutropenia, which this patient has, hairy cell leukemia, and splenic zone marginal lymphoma. They have a lot of autoimmune cytopenia features. Multicentric Castleman's is another one. We've talked about that quite a bit. And the cool thing about multicentric Castleman's is it also tends to have a polyclonal hypogammaglobulinemia associated with it. And these are the other tumors that I'd prioritize in terms of liquid tumors that do this in people. CLL, very common, should think about it. LGL, probably think about it because of the neutropenia. Hairy cell usually results in marked splenomegaly, as the splenic marginal cell. So that is a little bit less likely. Multicentric Castleman, totally a fair hypothesis here. And just by analogical reasoning, wondering based on the intestinal thickening, whether this patient has an intestinal extranodal lymphoma that is doing all this. And I'm also tracking the hypothesis that what might be wrong all this time about the lymphoma hypothesis, and wondering if chasing down this incredibly positive ANA, could this be a very unusual manifestation of lupus, which would improve with prednisone and whatnot. So I think I'd be worried about Richter's. I'd be now chasing down the source of this by saying, is it in the intestine? And then also making sure that we consider getting subserology for the ANA, like anti-double-stranded DNA, and so on and so forth, to try to clarify that gap. Honestly, because of how positive this ANA is, I think the most productive energy is to get those subserologies, because those other hypotheses are probably involve invasive procedures like biopsying the intestine and whatnot. So I'd probably stop and say, well, hold on. What is that subserology? Has this been lupus all along? And go from there. Any other thoughts, Ravi, before we hand the mic back to Ariel?
Oh, that's incredible. I just love that, the thinking that you're trying to balance 2 or 3 things at one time and sort of swing between them. Because even these topics can be very difficult. I find them these topics, plasma cell dyscrasias, to be difficult and not in my usual vocabulary, daily vocabulary in medicine, but trying to at least explore one. But then, yeah, going back to what about this ANA? That was fabulous. We kind of touched upon it, but we didn't really ponder much on it. But yeah, this could be a very atypical form of lupus, and lupus is the great mimicker. So I give you kudos to going back to that, because that could be the answer.
Yeah, I don't know, based on many mistakes, I feel like sometimes when the clinical course goes wrong, instead of looking forward for more data, you look backward and see what you might reanalyze. All right, Ariel, tell us more.
Great. I absolutely loved your discussion. One thing is that I have a suspicion that a lot of the disease processes that you shared in your schema, we probably have that in veterinary medicine too, but we just don't have the diagnostic markers for that. To be fair, this cat was seen and managed in a tertiary veterinary hospital, supposedly the best vet school in the world. Like for 99.9% of the cats with similar problems, they just don't get a thorough workup like this. And even in the tertiary teaching hospital, we just don't have those tests at hand, those serology tests to differentiate one form from another. Like we have an ANA titer and then that's it. Like if we want to dig any deeper, we don't have any markers to differentiate that. So bear that in mind. Oh, and one more piece of information. We were thinking about intestinal lymphoma leading to this type of manifestation in the first visit too. They actually did a fine needle aspirate of the spleen and the liver of the cat. They didn't do the biopsy of the intestinal tract. That's more invasive. But with FNA, if it is a lymphoma type of disease process, it's pretty sensitive and specific. And the aspirate showed like no specific pathology in the liver or in the spleen. And on the recheck visits, as well as the visit I'm talking about right now, there's no peripheral lymphadenopathy or organomegaly. All right, and more lab work on this final workup. So on recheck, he had again a macrocytic, normochromic, non-regenerative anemia with hematocrit of 17%. He had a mild leukopenia, but absolute count of neutrophil was low normal. Eosinophil count was low, but he was on prednisolone for almost 3 years. He had a mild thrombocytopenia with macroplatelet seen. Chemistry panel showed an elevated total protein of 9.9 gram per deciliter with 6.7 gram per deciliter globulin. He had mildly elevated glucose. Everything else, including electrolyte levels, were within normal limits. Abdominal ultrasound was pretty consistent with last time. Fine needle aspirate of liver and spleen, again, had no specific findings. Serum protein electrophoresis showed a tall, narrow peak in the globulin fraction that labels with IgG, low avidity, and light chain, and accounted for 3.77 gram per deciliter of protein. So monogrammopathy. And bone marrow aspirate again showed a decreased number of megakaryocytes. Erythroid and granulocytic lineages are present and orderly, but marked decreased in numbers. The granulocytic to erythrocytic ratio is approximately 1:2, which is again decreased. There were abundant plasma cells individually and in aggregates, including Mott cells and flame cells. And there were still a moderate number of small lymphocytes seen on the bone marrow aspirate.
Is that it?
Yes, that's it.
All right, Ravi, what do you think?
I was scouring or looking through the chat, and multiple myeloma came up with, especially with the IgG, you can't help but associate that with multiple myeloma. So I was looking for the IgM spike, but that was not within the data. But yeah, it's still, it looks like now we're seeing the associated cytopenias, leukopenia, thrombocytopenia, anemia. So we have a pancytopenia, and the protein gap continues, but there was no findings in the liver and spleen, which is a shame. So no answer there. But then I think we go back to exploring the differentials that we previously discussed, but nothing much takes the lead, except now we can introduce multiple myeloma along with the crowd. So the power of the crowd is also entertaining multiple myeloma. What do you think?
No, I completely agree. It always makes you wonder, like, did this monoclonal protein emerge, or was it there the whole time? And the SPEP, which is only 90% sensitive, 10% false negative, was it there all along? I'm curious if it was multiple myeloma all along, or because the therapy that we gave, cladribine and prednisolone isn't so myeloma avid. And here it's hard to argue against it. You have plasma cells that aggregate and you have a monoclonal protein. That is a very strong case for multiple myeloma. But if you were earnest about the arguments against it, is there's no bony lesions that we recognize, and there's no hypercalcemia. And the hyperviscosity is definitely can be with multiple myeloma, but it's more Waldenstrom-y. So I don't know. I think it's multiple myeloma is very plausible, but there are holes in it. Waldenstrom's is equally plausible because you have plasma cells and lymphocytes, but the protein is monoclonal protein is IgG, not IgM. So can I tell you where I'm at? I give up. I have no idea what this patient has. I have no idea. I think it's one of the few cases I think we've had where it's like it gives you a little bit to work with, and you get closer and closer, and it snatches it away. You're like, oh, plasma cells, IgG, monoclonal IgG, and that's like, oh, no bone lesion. So this is stretching my clinical reasoning beyond what it can do. But I think the clinical phenotype is Waldenstrom's because it is small lymphocytes, plasma cells, hyperviscosity. The biochemical phenotype with monoclonal IgG is myeloma-like. So maybe our division is arbitrary. Maybe there's a disease in the middle that I don't know of. But either way, I think we need Ariel to guide us here, unless you have any final thoughts, Robbie, before we humbly cede the mic here.
A question here, the aggregates, is that rouleau formation in a peripheral smear? I was sort of looking for rouleau maybe for multiple myeloma, but I'm not sure what that terminology, there's quite a bit of terminology that I'm not familiar with, but I absolutely agree with you. We have a good number of thoughts. Again, I don't know. It's sort of like one pops up, then the other one, there's some evidence swinging the needle to that one, but I think we're pretty close. And I think you're pretty much caught on to what is at play here. And I'm definitely right in there with you with those few diagnoses, but we're going to learn from Ariel what was the final diagnosis. Any other thoughts before that, Robbie?
No, I was just going to say, this reminds me of what I do with my dog all the time. We literally play a game of ball. I dangle the ball close to him and he gets close and I pull it away. And I feel like that's what's happening to me right now. I'm getting close, and then Ariel pulls it away. So I may never play that game with him now that I know what it really feels like. All right, Ariel, like to you.
Thank you so much. Actually, I have nothing more to add. You guys nailed it. We are also in the conundrum of whether this is CLL leading to a plasmacytosis type of presentation, or was it multiple myeloma to start with, and it was just hiding in polyclonal gammopathy to start with. We don't actually know. So the final diagnosis was made on the second bone marrow biopsy, which is pretty like phenotypically, multiple myeloma. But when we look back on the case presentation, there are holes to this presentation. So again, in veterinary medicine, we many times don't have all the resources to, dive in for a final diagnosis. Luckily enough, to treat the CLL or multiple myeloma, the answer is the same. We do chemotherapy and with pretty similar drugs too. So with this cat, we started chemotherapy right after, and he responded to it really well. It's 4 months post the second big workup, and his clinically doing fine. His bloodlines are coming back up. I presented this case because I talked it over to multiple veterinary pathologists, and they were also in, your shoes exactly. We don't know what is leading to which. So I'm very glad to listen to your side of the analysis.
Hey, Robbie, please bail me out. I babbled so much last time. I don't have any left to offer.
Yeah, I think this was a superb case. Just look at the journey where we started, and definitely we were going through anemias, weight loss, and honing in on possible malignancy. What kind of malignancy, as Robbie mentioned, liquid malignancy. But we sort of journey through the vast landscape of different malignancies. And you're exactly right, Ariel. This polyclonal finding was very confusing because we associate that with like all sorts of infections or inflammatory disorders, which was clouding our viewpoint of what could be truly going on behind the scenes. And we were looking for that one single solo spike. Could it be IgG? Could it be IgM? But it kind of switched up there. The patient got better and then started getting worse. So we were trying to relate that to maybe the CLL and what can happen with CLL. But then, any number of these different diseases can change into, you can have tumor lysis syndrome, other complications, infections, and, we don't really know what happened here. But I think we're pretty close as well. If you get very close, some of the treatment can be similar. And it was great to hear that the patient got better and responded to treatment in spite of not really knowing what was at play here. But it's incredible just to be able to discuss all of these different pathologies within the context of a cat. I didn't expect to be discussing a cat. I know we've had pediatric patients, but this is the most extreme case I've probably listed. I didn't even envision being on today with a cat case, but gosh, I've just by discussing all these different conditions and also then learning from Robbie, I definitely have been educated quite a bit. And from what you've also mentioned as well, it's been very educational. Back to you, Robbie.
Robbie, I feel so bad because here you were, it was noon, you were minding your own business, and all of a sudden I was like, oh, Reza's not coming. We discuss it. Oh, by the way, it's a cat case. So I really appreciate your trust and the vulnerability, but the truth is you don't need any of those things. I think it was a delight to hear your reasoning and to learn alongside you. And Ariel, I don't know what to say. I think you've definitively proven your hypothesis about wondering whether veterinary cases live on VMR. They absolutely do. They're humbling. They teach us a lot. And it's so obvious you put a lot of thought and work into this presentation, just given how organized it is and how linear it was, beyond your control. The chaos was beyond your control and inherent to this case. Do you have any final reflections on this case before we pass the mic on to teaching points?
Yeah, I do have a few teaching points. I think one of the confusion here is the ANA test. We actually don't know how to interpret that. I asked the pathologist, like, why did we order the ANA? And he was like, yeah, I don't know why they did that. Lupus is not a very common diagnosis or an easy diagnosis to make in veterinary medicine. Usually we rely on at least two separate immune-mediated disease, as well as a high ANA titer to make that diagnosis. And this cat doesn't fit that criteria. I think the clinician ordered the test trying to rule it out, but it came back positive, so we don't actually know how to make of it. Someone was asking in the chat box whether multiple myeloma is common in cats. It's not. It's a rare hemogenous cancer in cats, as well as CLL. They're not common, especially in a cat this age. So it's a rare representation. And I guess a lot of the medical points wouldn't apply here, but I just want to, make the point clear that if you have pets at home, consider getting pet insurance when they're young and healthy, because all these medical tests that they might one day need, they're very expensive, and all of the money comes out of pockets from owners. And this cat, looking at the bills, like tens of thousands within the last 3 years. This cat has been really lucky to have devoted parents like this, but usually we don't get that lucky. So consider pet insurance.
Love that.
Oh, and maybe next time I will present a veterinary neurology case, which is maybe the ultimate challenge.
Oh my gosh, that'll be unreal. Thank you for all that learning, both practical and medical. I appreciate it. I don't know if you saw it, Deborah wasn't even slated to do any of the active work today in VMR, but she jumped in to help my abysmal scribing skills and add to the teaching points. Deborah, do you feel comfortable doing the teaching points, or do you want me to recant what I wrote? Let me know.
No, I can do it.
Okay, all right.
I was paying attention to the case and I didn't write much. I'm sorry, but I will fix it.
Sure.
Great case. Thank you so much. Like, I never thought about the cat could be so similar as a human, but we are always learning. So we saw that in the human years, the cat years can be 4-7, and this weight loss could be a loss of intake or can be an intake loss. And the anemia, we have to check if it's isolated base cytopenia, pancytopenia, and then we have to look for the time course, acute, subacute, and chronic. And in this case, we thought about there was a malignancy involving the bone marrow and the intestine. And then we thought about the wildness from macroglobulinemia, that could be the bone produce too many abdominal white cells that can produce the protein accumulation. And then Robbie showed the schema of cancer and autoimmune that could be liquid, thinking about lymphoma, leukemia, and other, and solid that could be like a thymoma, adenocarcinoma, and arthritis. And then Ravi said that the lupus could be the great mimicker, and the multiple myeloma, we have the crab, but Ravi always says that is the bone that causes anemia, that causes renal failure, that causes the calcium. And the treatment in cats is almost the same as human, with the chemotherapy with almost the same drugs. And we learned that it's not common in cats, especially in this age. And in this case, the ANA confused why so high. So in the lupus is not an easy diagnosis in veterinary. So thank you so much.
I can't believe you did all that and scribed and teaching points. It's absolutely amazing. Thank you all. Thank you, Ravi. Thank you, Ariel. Thank you, Deborah. Thank you, everyone, for joining. We'll hope to see you all next time. Okay. Bye.